Okay, thank you very much. I'm going to tell my wife you said that.
Please do.
Okay, right. I'm still sort of, the last panel is resonating in my brain. I think I think in part, I've been so focused on the current structure of Healthy People that this has kind of expanded my thinking about it, just having heard that. But our focus in this panel is on data, and it says data sources. I thought I would begin in, I hope, much less than 15 minutes, and just give you what I think are the key points that have come up in Healthy People 2030 regarding data. And one relates to, George, your last comment. First, the first point is that the objectives have been chosen, or I should say are chosen, since they're not final at this point, but the objectives are buttressed by having interventions associated with them that are feasible to make a difference. It doesn't mean it does it across the board, but it's not an objective that doesn't have some evidence that that objective can be moved over time. I'm talking about the objective and not the LHI, but as I understand it, the LHIs are to be chosen from the objectives. Secondly, a major new emphasis, it's been there in the past, but I think that it's a major change, is on state and local action. It's not, it's really been emphasized, particularly as we talked about data. I'm not sure you have this document called Summary Measures of Health and Well-Being. I'm not sure everybody has that. I'm looking. I know.
It's been provided to the committee, and I believe
We
it's been
have
in the
it, but
briefing
anyway,
book,
there's a
so.
recommendation in there that starts with number 20, and it emphasizes that and focusing in part on state and local data, particularly on the local side, raises challenges. Okay, it's a challenge of asking the question, how does local data, community data, relate to state data and national data? Okay? Is it the same? Is it possible to aggregate with a large sigma sign the local data and have it mirror the national data? We don't know the answer to that because we really don't know what local communities, county health departments for that matter, are or will be using for their data sources. There's also a recommendation that the national objectives be, and the word is adapted to local data, local conditions, which is an interesting, I think, addition that I haven't seen before in Healthy People. And then again, it raises the question about the national objectives and how those will relate to what people see at the local level. So one of the questions that I'm coming to here associated with local and state data is the challenge of understanding progress. We can look, as we have nationally over the last many decades, in assessing progress. But then how do we look at it at the local level, and how do we relate progress at the local level to the national level? Which brings me to point 3, which we've emphasized, which is how to do it. Now, it's one thing for people in the National Center for Health Statistics to analyze the data, and this is something they do all the time, and I'm looking at David, who does this, or people in the Census Bureau and so forth, and analyzing this. But when we come down, and I don't mean that in a negative sense, but when we move closer to the population, look at smaller figures, and how do we how do we analyze this data? How do we collect new data? And do people at the front lines in health, do they have the front lines in public health? And when I say public health, I don't mean solely the public health schools and so forth. I mean, broadly speaking, public health. Do they have the knowledge, and how do they, from what experience can they draw? Perhaps experience at the national level that can somehow be tailored to them. And I'll come to a point about this in a second. So there's the analysis of data, the collection of data. There's assessing the quality of data. The question was asked earlier about data sources outside of NCHS, other national data sources. There are many of them, and they're all judged at the national level in terms of the quality of that data, how it's collected, how it's analyzed, and so forth, and that's absolutely critical. But when we leave the National Center for Health Statistics, which lives and breathes this, and we get at other levels, how do we go about judging quality? What guidelines do we have for that? My fourth point is that data is going to change over the next decade. The nature of the data, the information itself, the growth of the data, in fact, it may get massive. And how do we deal with that? And you'll see why I say massive in a second, speaking to the speaker on my right. How are we going to deal with that? I don't know how many of you follow Jeopardy, but there's a fellow on there now who is winning, who is a professional gambler. So that leads me to say I would place a bet that by the time 2030 rolls around, we're going to be looking at the current data structure. This is my speaking, not the committee, but I think we're going to look at it as primitive in terms of the information that it provides and the need to add much more to that. So that was my fourth point, which leads to the fifth point, which has to do with something that we are currently working on called data partnerships. And this notion came up from our committee, our data committee discussions, that it's important and will be very valuable if we can develop a structure to share data, to share analysis, to share methods, to share insights across the country. And this is not only for healthy people, but beyond that as well. And I think the prior panel, really emphasizes that we could be in a very different place as far as data goes. So that's what I wanted to say. To me, these are the five sort of new emphases that I think it's likely that we will see in Healthy People 2030. So we're not reading the long paragraphs, but let me start with, I'll introduce both speakers, and I'll start with Amy, who's on my right, who's a former colleague of mine from the Census Bureau, which it doesn't say here, but we all go back some years, many more years than you, obviously. But Amy O'Hara is a research professor in the massive, I love this, massive Data Institute at Georgetown University's McCourt School of Public Policy and the director of the Georgetown Federal Statistical Research Data Center. And to her right is another former colleague, Ali Muqdad, and I guess when you're involved in all this data stuff, you continue to be colleagues. Ali Muqdad is professor of health metric sciences at the Institute for Health Metrics and Evaluation, IHME, which certainly is legendary at this point, and chief strategy officer for population health at the University of Washington. And it doesn't say it here, but I think it's really important to say that Ali was at CDC and one of the drivers of the BRFSS, which is a crucial data source outside of NCHS, but part of CDC, again, that adheres very carefully to the best methods possible in conducting surveys, the behavioral risk factor surveillance system. I always want to say surveillance system. So with that, let me turn first to Ollie.